by 90, and her otherwise systemic examination was found to be normal as per the records. She was started on cilnidipine. Family history wise, she had a family history of mother had sarcoid and diabetes, and she also was on some hearing aids. Father had a history of CVA and hypertension as well. There were two brothers, one had diabetes and hypertension, and the mother's sisters also were on hearing aids. Her evaluation was done and the creatinine was 0.6, electrolytes was fine, and urine routine showed 1 plus protein with 15 to 20 RBCs. Ultrasound showed right kidney 8.5, left kidney 9, and one small 4 millimeter calculus, which could be the cause for hematuria. That's what was thought. Although CT was found to be normal. They did ANA, ANCA, which was found to be negative. Complements was also normal. Viral serologies were non-reactive. And ambulatory BP monitoring was done, and the maximum blood pressure during this episode was found to be 188 by 121. There are a couple of readings like that. So, and echo which was done, which didn't show any left ventricular hypertrophy at that time, and ejection fraction was 65%. So she underwent a kidney biopsy at this time, and I don't have the slides of the biopsy, but the report which she brought showed that there were 28 glomeruli, one was globally sclerosed, and 2 out of remaining 28 had mild focal segmental sclerosis. IF was negative, blood vessels showed some hypertensive changes, and electron microscopy which was done showed normal basement membrane thickness. Bilateral sensory neural hearing loss, left more than right. Ophthalmic examination suspecting Alport's they did, and there was no lenticonus, keratoconus. So repeat renal biopsy was done in June 2017 in Mumbai itself, and they found there were 21 glomeruli, and one was globally sclerosed. The rest, once again, interstitium was normal, and immunofluorescence showed IgM faint positivity. Basement membrane more or less was fine. So it was opined that, okay, there are no features of TBM, Alport's or IgA as per the biopsy reports. Now at this time, she came to Delhi. So in fact, has to something do with the next part of the today's program also. She had heard about renal denervation, and she had come there. So she saw in cardio department she was seen, and the pressure was that time was 140/70. She was on medications, metoprolol, XL 50 mg once daily, amlodipine, and a combination of telmisartan with chlorthalidone, and moxonidine was also added. On further evaluation which was done there for these episodes of accelerated hypertension, renal Doppler was normal, stress echo was done which was normal, and the 24-hour urine protein estimation showed 600 milligram proteinuria. She was seen by a nephrologist there, and the renal biopsy slides were also reviewed, which showed some alternate thin and thick basement membrane, which was suspicious of Alport's. Now, she came back to Mumbai because she used to stay there, and the hematuria episode once again started. So she was seen by a nephrologist there, and she was started on oral prednisolone, and that she was taking. Now, for the evaluation of sensory neural hearing loss, MRI brain was done, which showed acoustic neuroma in the left auditory canal. She was started on carbamazepine because she also started getting trigeminal neuralgia. Once again, she visited another hospital in Delhi. She was just going around for multiple opinions because she was obviously not getting the answer. She belonging from the research field. She had a very sharp brain and in search of the answers. In fact, she had come to me with slides of all her presentations and all the details. So my work was actually very easy, but the case was difficult. So her pressure was 234 by 132 when she visited Apollo Delhi actually. And she was on amlodipine, moxonidine, prazosin, lercanidipine was added. Prednisolone, she was on 40 milligram at this point of time, carbamazepine for her neuralgic pain. These were the medications, and then she went, and the labs which showed once again normal kidney functions, no red blood cells, urine protein creatinine ratio well within normal limits. So labs wise, it was fine. And then once again she was back to escorts. At this time, actually, I saw her. So this was in Jan 2018. Her blood pressure in the office was 220 by 131 ASO, and she was sitting nicely and calmly. And she was saying, I'm used to this. And there was no significant difference between the limbs. Her BMI was 24. There were no bruit. So it definitely didn't look like a primary hypertension the way her readings were. It was looking like a secondary of non-renal parenchymal origin. Now, when I was discussing, I mean, we were having a chat, and Dhananjay sir said that she must be having hypokalemia, and I busted the case. So, so no, she didn't have any hypokalemia. In fact, she was on telmisartan with chlorthalidone, amlodipine, prazosin, multiple medication, and prednisolone. We didn't find any use for prednisolone because obviously she didn't have much proteinuria to begin with, and it was a secondary FSGS in all probability. And so we tapered and stopped it. I tapered it and stopped it. So now starts the workup for her secondary hypertension. So first thing that we normally would like to rule out is any pheochromocytoma, adrenal adenoma. So worked up for that. Her plasma-free metanephrine level was 137, which although was elevated, but it was not elevated enough to give a suspicion of pheochromocytoma. In that, usually it is multiple times higher than that. Her 24-hour urine for adrenaline, noradrenaline, VMA, everything was normal. Now, I did all the changes in the medications, whatever you need before doing these tests, because there are a couple of medications that you need to stop, and which makes it even more difficult because she's already on so many medications, the pressures are really out of control. But somehow we could manage that. Her plasma aldosterone ratio, renin ratio, we did a plasma renin activity and plasma aldosterone concentration, what we do for these patients, everything was normal. She also underwent a CT KUB, and there was no renal artery stenosis. There were a couple of small stones, but there was no adrenal mass. So that it has to be done in a particular protocol, which is called adrenal protocol that they do. So just doing a CT won't help. You have to tell them in advance that you are suspecting this and get the CT done. Meanwhile, she visited Singapore to get operated upon for acoustic neuroma, but surgery was denied to her. She said the pressures are way too high. We just can't touch it. It will bleed like anything. Catastrophic. Now, in March 2018, she again came, and this time she started having tinnitus also, apart from the neuralgic pain what she was having. Her blood pressure was 220 by 140, and she was on multiple drugs, as you can see, including minoxidil also, which was added as the last resort to control it. She was asked to stop carbamazepine at this point, and so it was still intriguing. I mean, it was not clear what I was dealing with. She used to come for a few days, get evaluated, then used to call after some time that I'm here, I'm doing this, and still I'm in trouble. So I went back to book, checked for the things, what all, if anything I'm missing on. So primary hypertension, definitely not. Secondary hypertension, renal parenchymal origin doesn't look like that. As we know, I mean, somebody with the normal kidney functions with minimal proteinuria, we don't get such hypertensive patients. Renovascular, we ruled out renal artery stenosis. Endocrinologic, hyperaldosteronism, pheochromocytoma, hyperthyroidism or hypo, all these were ruled out. Cushing's, she didn't have any features to suggest Cushing's. Diabetes was not there as per records and the tests. Now, sometimes congenital adrenal hyperplasia with hypertension, but no, I mean, she was not fitting into that, and all of them are low renin state. So obviously you are not going to, and the renin here was perfectly normal. Coarctation of aorta, obesity, drug use, no, nothing like that. And and rare causes like carotid body tumors, all these things were ruled out. So now the thought of neurogenic hypertension came. Now, so how it can happen in this patient? Because nothing was coming positive actually. So now I just went back to what acoustic neuroma can cause, whether that can be a cause of hypertension. So as we can see, the acoustic neuroma, if I think we had a neurologist just now, he went outside, otherwise, so this acoustic neuroma, if it expands, it can press upon trigeminal, ganglion, and it can lead to trigeminal neuralgia. So that can happen. And then if it expands further, it can obviously press upon the facial and the, vestibulocochlear nerve, and that can lead to facial paralysis and involvement, lead to tinnitus and other things which we are talking about that she started getting. And further, it can compress upon the cerebellum and can lead to cerebellar symptoms as well. And then if it goes further, and then if it compresses this cranial nerves 9th, 10th, it can cause hypertension. So, but this usually will happen very late. It won't happen initially. So, although fine, it was looking like it could be related to this, but still it was not explaining the things. So now, meanwhile, her symptoms were worsening. She started getting right trigeminal neuralgia, very bad tinnitus also, and she had severe and profound hearing loss on the right ear and hearing loss in the left as well. So both the ears. She underwent meanwhile a stereotactic surgery, a radiosurgery for left acoustic neuroma at Apollo, and that gave her some relief but not complete. And she underwent a MR angio. Now this MR angio which she underwent of brain was suggestive of vascular loop against left 8th, right 8th and right 10th nerve. So meanwhile, I shouldn't forget, but the denervation thing which she had come for and which was thought also, but the problem is if you look at the magnitude of fall in the blood pressure with denervation, that's not that high. It will be like 15, 20 as per even the trials and whatever is done. And the kind of pressure that she was having was way higher. And with these pressures, every few months she will just, land up and she will say, "Doctor, I am still alive." So now this particular cause of loop. So these loops, the vascular loops, there are these arteries, the anterior inferior superior cerebellar artery, which can press upon, they can form loop and they can press upon trigeminal nerve and cause that trigeminal neuralgia. Similarly, so this is, if you have a loop of ICA, anterior inferior cerebellar artery, that also can compress upon the nerves. And if you have a loop of pica, posterior inferior cerebellar artery, it can also compress upon the 7th nerve, and it can also compress upon 10th nerve. And this can also lead to such severe cases of hypertension because it alters your parasympathetic pathway and reduces the inhibition. It can lead to sympathetic hyperactivity, and that can cause hypertension. So finally, I was kind of zeroing in on this particular thing that after ruling out everything else, mostly it is this particular cause which is leading to this uncontrolled hypertension in this young lady. I went through literature to see what we can do if that is the case. So by this time I had gone to Medanta, so I discussed that with the neurosurgeon over there. Can we do something for this? And she was seen at CMC as well, and she was advised that we can do a decompression surgery for these. And this, there is series even from 1990s, in fact, there are publications, and this one also is there. This publication was about, hypertension of neurogenic origin, where they have done the microvascular decompression of the cranial nerve 9th and 10th root. And it was a series of 48 patients. And so these were all, resistant hypertension cases, and hypertension was severe in all these patients. And so after the microvascular decompression, BP had returned to normal in about 28 patients, and 14 of these patients were able to maintain the pressures without any antihypertensive treatment. And these results, obviously, the authors said that it's very helpful for patients with this neurogenic cause of hypertension, this particular. But then the question was, nobody was ready to touch her. She was being sent to multiple places, and this was a theory which was being put upon. But and she at one time, we discussed of going to abroad because there was this particular center which was doing things, but then she didn't have social support to go to there and get things done. So she last messaged me in 2022 that I've come to Delhi. By that time I just came here. After that, whatever message I have done, she has not replied. So I just hope she is doing okay somewhere. But these were the crazy blood pressure readings, and she had changed, in fact, initial instrument multiple times, thinking that there's something wrong with the instruments. And I personally have not seen this high blood pressure. You can see the diastolic pressure was 172, and she was just roaming around with these pressures. So this, after this all workup and everything, I feel that mostly it was a case of neurogenic hypertension, and whether decompression would have helped if, although it's really, really difficult, and it can, the area where this particular decompression will be done, that is a very, critical area. So obviously it is next to the medulla. So if anything happens, it's, so nobody wants to touch it easily. Thank you. So this was the case that I had to present. And
often after combination of multiple drugs, we zero onto hyperaldosteronism. Primary hyperaldosteronism is quite common, though your aldosterone levels were normal. But in such a situation, to give aldosterone antagonist is one of the ways to control the blood pressure. If the BP is not controlled with so many multiple drugs, then aldosterone antagonism may help.
yeah, so she had received that, which I think I didn't show, but not in like high doses, like 50 milligram of something spironolactone she had received. Now, we can have, in fact, 50% of the cases with primary hyperaldosteronism, they need not present with hypokalemia also. Your potassium will be normal. But it is very unusual to have primary hyperaldosteronism with completely normal renin and aldosterone activity, plus no CT imaging suggestive of any hyperplasia or tumor. Other way it can happen. You can get a incidentaloma or something like that, and you can have a normal PRA and PRC, and you have thing. But here everything else was normal, and she didn't show any that dramatic, because in that case, as soon as we give spironolactone, the control is very good. Usually, I mean, they get a significant drop. But that was also not seen in her case. She received everything, in fact. Hematuria, mostly she had that in CT, the next time when we did, she had multiple small stones. So mostly it was that leading to hematuria. And because even the biopsies, at no time, because at one time even IgA nephropathy, Alports, all these were entertained, but none of the features were found in the biopsy. So mostly it was the small, these stones which led to hematuria on a couple of occasions. And the last of which in fact happened in 2016 or 17, which I showed. After that she didn't have episode. So in July 22, before I came here, before that she was admitted with a stone which had fallen down and blocked the ureter. So it must be that causing the hematuria again and again, mostly.
And which readings you showed on the manometers? All shows the tachycardia.
Yes.
117.
So that once again supports the hypothesis that mostly the the inhibitory activity is being inhibited, and which is leading to higher sympathetic activity, which is causing this hypertension. So if we don't have a FeO, then what else can lead to such high sympathetic activity? So mostly then it goes once again to the medullary part, and our neurologist can tell us better here. Dr. Dhruv Batra is a neurologist at Viveka. So Dhruv, do you see such cases?
So incidentally, I am a movement disorder specialist. So I think nearly many patients with hemifacial spasm come to me for botulinum toxin injection. I have yet to see a patient with hemifacial spasm who does not have hypertension. I mean, it very well proves this number one thing is that, because that is the first thing. And second thing is, amlodipine has been used to treat trigeminal neuralgia. I mean, I'm now talking about the other way around, because it is hypothesized that not only the loops are compressing these nerves, but it is the pulsatility of these vessels, right, which is more important in the sympathetic overactivity. So the study, it's a very good article. I mean, it's on Google, you can go through it. It's in our journal. Amlodipine was tried in these patients because it was the antihypertensive which reduced the pulsatility of these blood vessels to the maximum extent, and hence it was a good drug for refractory trigeminal neuralgia by reducing this pulsatility and this thing. So, I mean, this is very, very well documented from our side, because we see a lot of hemifacial spasm and these patients, and almost all of them have hypertension. So, from our side also, it matches what.
And how high is that? I mean, does it go this high?
No, I mean, not this high, because I think in this case, I just missed the part that, was it also compressing the 9th, 10th end in her
Yeah,
case?
so the MR angio which was done, so that showed the loop of left eighth, right eighth, and she had this features, I mean loss, hearing loss, which was sensory neural, and she had right 10th nerve compression as well.
So, I mean, this is very unusual from our side also, in the sense that so many compressions of
Right.
vascular loops at serial levels, it's, I mean, just unlucky, I think, pure
Yeah.
unlucky. Because
So when I went through, I mean, the literature, so there are obviously there is this hypothesis that this hypertension itself worsens because hypertension leads to more, elongation and loop elongation, and that in turns compresses the nerve further, which in turns accelerates the hypertension further. So it's like a vicious cycle which happens in that.
and I mean, this is very unusual, because usually you will get a loop involving either the left 8th, 7th, 8th complex or the right, but both, and with that again the 9th and 10th, I think it is purely unlucky. And more importantly is that many of these patients, when they go for microvascular decompression, like a patient with hemifacial spasm or trigeminal neuralgia, I mean, in spite of the surgery, when you sort of put something in between the loop and the nerve, it recurs after 2 to 3 years. So we still don't know whether it is only the contact which is responsible for it, or is there something else? Because if you put in a physical barrier, and if that is itself the cause, the trigeminal neuralgia or the hemifacial spasm should not happen again after 3 years. The failure rate is as much as 60 up to 60%. So maybe some other mechanisms at play, but not very simply mechanical compression is the what is from our side.
Manoj, yeah. Yeah, it's an acquired. So once again, in this lady, another, I think Dhruv also will concur with that. Mostly these conditions happen in older age when your artery tend to get atherosclerotic, and the loop formation is more common in that. And then this cycle which you just spoke about, the vicious cycle of one begetting the other happens. She was young, and her hypertension started at roughly 38 years of age. But the way it progressed, and with all these things happening in the mind, with the tinnitus, with hearing loss, so more and more it favors that most probably it is a neurogenic hypertension. I mean, I could not get any other secondary cause. Like we see a lot of patients with secondary hypertensions, renal and renal parenchymal renovascular. It doesn't behave like this. This is way too high.
One striking thing in the history is the mother was also deaf.
Yes.
So now acoustic neuromas are
A
about
familial
5%.
condition.
Yeah.
Yes, sir.
And then they may be associated with neurofibromatosis.
Exactly.
So maybe genetic testing
possible
could help.
So, but she didn't have any other features as such apart from this acoustic neuroma of neurofibromatosis as such. So we did look for the syndromic association, because as you rightly pointed out, and that was the reason of putting it here also, that the family had this history of hearing loss. So which was interesting, but didn't lead much. There was no syndromic thing what I could find after examination and other things.
With or without this proven relationship of acoustic neuroma with such severe hypertension, would she not have been subjected, a candidate for neurosurgery even otherwise? She was having progressive hearing loss.
So as I said earlier, that with the pressures of 250, 150, it was really difficult for her. She did get admitted for some other
centers.
She
She went to
did-
Singapore. So
yeah.
is blood pressure still such a big thing that
I don't know,
surgery
from
is-
Singapore they sent back. I mean, they agreed with the workup. They said that very well worked up, but we can't touch here. I don't know what was the factor, but she came back. And then next time when I asked her to go to, I think it's a Korean center where they were doing, if I am not wrong. So, but she was, that time she didn't have this enough support to go there and stay. And she was rightly saying that if something happens to me over there, Then I'm in a foreign land with one of my relatives, if at all, and then I can't manage. So she unfortunately could not go. And okay. So she has gone to, I mean, if I start counting the hospitals, she has gone to CMC Vellore, she has gone to Apollo, Ascot's, Medanta. Obviously, she came when I saw her, and then these are neurosurgery departments. And then she was in Mumbai, so she had gone to a couple of big hospitals over there. But unfortunately, even she underwent a stereotactic surgery. That was one thing which was done, but I don't know how they managed it over there. And after that, so I really don't know what happened after 22. I just hope that she's there. I really don't know with all these things.
People in Singapore are trained from these institutes only.
Right. So that's why they referred back maybe. Yeah. So, but it was a different case, which I mean, there are few cases in life. I feel that every time we see that, so you feel good that you worked up, but at the same time you feel so inadequate that you could not do, maybe the best thing what you could have done, and so that is one of the cases. So,
In such a situation, renal denervation,
right.
that's one thing that
Yeah. So once again, sir, that's what I was saying that I mean Jagtap sir is here, so he will talk about denervation therapy in detail. But and she had come there for that, and I had sent her to cardio also for that once again. But the problem is the magnitude of the fall in the pressures. If you look at all the trial, including simplicity and whatever is there, it has not been that great. If it's, I mean, it's 15 to 20 in systolic, 15-20 से तो सर उसका कुछ होने ही नहीं वाला. Diastolic ही 170 चल रहा है. Yes, sir. I think I will just show the previous part. So these are all the things she was on, and as sir said, in between spironolactone as well, and matlab, I didn't have any other medication to add, and it was everything is one in supra normal dosage, what we normally use for our dialysis patient. So like that.
You don't seem to be impressed with nifedipine.
Sir?
You're still using amlodipine.
Huh?
You still seem to be using amlodipine.
So I am very fond of amlodipine. Unless until somebody gets, if somebody gets edema, I just, okay, I take it out. But amlodipine, I'm a big fan.
what about the peripheral vasodilators?
So directly acting I have used minoxidil. But even with that also, I mean, minoxidil तो हमारे यहाँ वो ब्रह्मास्त्र की तरह रहता है sir. If nothing worse, obviously edema and the fluid overload is one thing which bothers us in patients. But if somebody is not, after all this medication, minoxidil को भी respond नहीं किया, तो I really become clueless कि अब क्या करना चाहिए.
Combination of cardiologin with nitrate, isolazine.
Isolazine. Yes. So she has been, because this was a therapy with me, but she had gone to multiple places and everything was tried. Like at one time this, at one time that, and in all the combinations.
No stroke, no ISD, no LVH, nothing.
Yeah, I mean, that was surprising. That was once again very surprising. Till the last time when I saw her, initially it was episodic in 2016, 2017 when it started, 2015 I guess, episodic, but later on it became persistent. And she was like, whenever she used to come to sit in the OPD and pressures were 250, 130, every time she will go to a physician or a neurosurgeon, first thing they will advise you get admitted. And every time she will say, I'm fine, don't worry for that part, I've come for this thing. If there are no further questions, ma'am, I will hand over the proceedings to you to take. Jagtap.
Very excellent cardiologist amongst us, brilliant cardiologist, I will say, and who is also a brave cardiologist, that who has gone through so many ups and downs and always he has come out as a winner. So I am presenting you Dr. Jagtap, one of the par excellent cardiologist amongst all in Nagpur. So Prashant, you can start your talk now.
Well, thank you for a nice introduction, Dr. Acharya sir, and very senior nephrologist amongst us today, Dr. Acharya, Dr. Khaitan, Dr. Ukhalkar. It's indeed a pleasure to talk amongst nephrologists for the first time ever. And when I became cardiologist, our knowledge was only if the creatinine is very high, we used to defer angiography. Then we started learning calculating eGFR and all. Then of late we have also started calculating the risk of nephropathy. So we have improved also as cardiologists, and we are now seeing a lot of patients of CKD, and this is of course because of the high diabetic burden we have. The concept of resistant hypertension, we deal hypertension every day in and day out, and some patients when they present to us, it becomes a nightmare even for a cardiologist sometimes, because the patient often comes to you and the BP is not controlled. You try this, you try Aldacton, then the patient says that potassium goes up, you have to stop Aldacton, then you start amlodipine, then he starts getting edema fit, then he's more worried about edema fit, you are more worried about his blood pressure, and then it's a difficult scenario. So hypertension was the only topic which was for the interventional cardiologist, there was hardly any intervention, but because whether it is a valve, whether it is a septum, whether it is a coronary, we try to invade the body by putting a catheter. But now hypertension also has come in the domain of an interventional cardiologist, and thanks to the numerous researchers, scientists who have worked on this sympathetic nervous system, and now this therapy is FDA approved, and about 25,000 procedures are done worldwide till now. And in India also it has been introduced about few months back, and about 29 procedures have been done in India. So coming to some basics, today is a World Hypertension Day, so it is very symbolic, and we understand that about 30% of the hypertensive patients are untreated, and about 35% are treated but uncontrolled, and 35% are treated uncontrolled. So this 35% is for a country like us, it's a huge number. And according to the latest guidelines, once you have a patient of a true resistant hypertension, meaning you have ruled out pseudo-hypertension, you have ruled out non-adherence, you have ruled out every other possibility, and you are left with a resistant hypertension patient, you have two pathways, and of course we have the triple combination. And then you add spironolactone or an alpha blocker or a central acting agent, and if the GFR is less, then you have the other group of drugs. So according to the new guidelines, renal denervation, if the GFR is more, because the evidence is only in GFR more than 40, so it is one of the options if all these therapies fail or the patient so desires. So why RDN? What is the renal denervation procedure? It is important to realize that even a 5 millimeter reduction in office systolic blood pressure provides a 10% relative risk reduction in major cardiovascular events. This is a very important point. So 5 millimeter reduction would reduce a major cardiovascular death by 10%, stroke, heart failure, ischemic heart disease, cardiovascular death. So if it is 10 millimeter, it is even more. So contrary to what we believe, a 10 millimeter drop in blood pressure over a period of time is simply great in terms of in terms of meaningful reductions in cardiovascular. That point has to be understood. So if you say that this therapy reduces blood pressure only by 10 millimeters, it is not only, it is significant, and it makes a dramatic impact, and this is what it says. So, contrary to our clinicians' belief, there is a lot of non-adherence among patients. Patients will not take drugs, they will miss doses, they will change their therapy. अरे डॉक्टर साहब वो तो आपने 2 बार बोला था पर वो जरा ज़्यादा ही हो रहा था, हम अभी एक ही बार ले रहे हैं. So they will give all sort of explanation, and so non-adherence is very important. Some patients would say that they are intolerant, and there are indeed some severe side effects. So apart from this, true resistant hypertension is despite maximum tolerable 3 doses of antihypertensive medications, which includes a diuretic and a long-acting dihydropyridine calcium channel blocker. So uncontrolled hypertension is one of the most important cardiovascular risk factors, and this is just the statistics, and I will show you what is the incidence of total non-adherence and partial non-adherence. Meaning about so many studies, 17% would not take the medications after 1 year, and about 44% would either drop a drug for some reason or the other. So this is the true state, and we underestimate, we take it for granted that patients are taking drugs, but it is not so. Patients are not taking the drugs fully, or they are forgetting, particularly if it is an afternoon tablet. So you have to be very careful, and you have to believe in polypharmacy, give combinations so that patients, are compliant with medications. Now this is a very unique and very innovative, I would say, renal denervation system, which is US FDA approved. And you can see it is a helical thing. I would come to the explanation why it is helical. Because of the past experience and past failures, they have designed it in a very beautiful way. With this helical system, there are 4 electrodes, gold electrodes, which are very important, which help in ablation. So coming to some basics of anatomy. Well, initially we thought that the main renal artery, before it branches out, is very important, and it is all covered with sympathetic nerves. But actually, the branches are equally important, and it is where the first mistake was made. In the first trial failed, which was published in 2014-15, the first trial of renal denervation failed because all focus was only on the main renal artery. But if you look at the plexus, it covers the branches also. So before it enters the parenchyma, you have to really treat all these branches so as to ablate the maximum number of sympathetic nerves to cut down the afferent and efferent discharge. So this is the basics, and look at this, this is the main renal artery, and look at the catheter, how it takes the shape, and it becomes like a serpent. The big advantage of this serpent is, it gives emissions in different directions. So all the, whatever you ablate, the nerves in that vicinity would get affected. So the kidneys modulate the sympathetic tone via the renal nerves to control the blood pressure. So this is one of the electrical way the kidneys help to control the blood pressure. The other way is humoral, and third is volume dependent, so physical. So this sympathetic tone, the renal denervation disrupts the overactive sympathetic signaling between kidneys and brain to reduce blood pressure. So obviously the sympathetic nervous system is working more, or it is overactive, just like it happens in cardiac failure. So cardiac failure, initially the sympathetic nervous system is protective, but later on it becomes dangerous for the heart. The remodeling occurs in the reverse way, and that's why you give ACE inhibitors, calcium channel blockers, and the latest drugs, ARNI drugs, because you don't want that sympathetic overactivity to harm the heart. In a similar way, when the sympathetic overactivity is more than the desired level, at that point probably this system works. So in genesis of resistant hypertension, every resistant hypertension is not sympathetic outflow or sympathetic overactivity dependent. Some resistant hypertension would be volume dependent, and probably in such cases this may not work. But majority of the cases when there is overactivity, there is a chance that this will work, and evidence has shown that it works in majority of the patients. So coming to how this system works, for an interventional cardiologist, probably it would be one of the simplest of the procedures. It doesn't require much. Taking a femoral artery puncture, putting a catheter in the renal artery, and then pushing the guide wire, and then putting the catheter here. Now, I attended the workshop and how to put the catheter and where to put the catheter and how to do the renal denervation. So,
which has been proven to reduce blood pressure. The Simplicity Spiral Catheter and Simplicity
so this is a spiral catheter.
Offer an extremely efficient and simple method of performing renal denervation. The Simplicity Spiral Catheter offers exceptional deliverability and ease of use, short procedure and ablation times, and consistency of deployment in a wide range of anatomies. The Simplicity Spiral Catheter is a 6 French compatible catheter that is delivered using a rapid exchange system with a standard .014 guide wire. When the guide wire is retracted, the Simplicity Spiral Catheter naturally conforms to the patient's renal artery without occluding blood flow. It is capable of treating a wide range of arteries as small as 3 millimeters in diameter and as large as 8 millimeters. The Simplicity Spiral Catheter uses the same helical ablation pattern established by the proven Simplicity Flex Catheter. The energy delivery from the Simplicity Spiral Catheter is controlled by the Simplicity G3 generator. The generator allows the physician to monitor the impedance and temperature measurements of each electrode. The RF energy is delivered simultaneously through all 4 electrodes and utilizes Simplicity algorithms that safely and effectively lower blood pressure. After a single 60-second ablation, the Simplicity Spiral Catheter is repositioned into the contralateral renal artery and the ablation procedure is repeated. The Simplicity Spiral Catheter and Simplicity G3 generator from Medtronic, the pioneer of renal denervation.
So, very, very elegantly designed, I would say. Because of the spiral shape, various quadrants can be taken care of, and in the same sitting, and the depth of the penetration of the radio frequency waves is about 4 to 5 millimeter. So it just involves the adventitia and beyond that. So it doesn't disturb anything. It doesn't disturb the renal vein or the intestines or whatever the other structures, the lymph nodes and all. So the penetration is not much. So this is very important, and the simple principle of radio frequency for cardiologists, radio frequency is routinely done in heart for radio frequency ablation of arrhythmias. But this catheter is different as compared to the heart catheter. The heart catheter cannot be used for the renals because the depth of penetration is small in this case. And if you look at the catheter design, one catheter size fits 3 to 8 millimeter, which is usually the size, and it is easy to use, plug and play design, and the non-occlusive design allows for the continuous blood flow to naturally protect the vessel wall. So when you are ablating, because of the heat, but the blood flow is going on so that the heat is dissipated, and there is no damage to the surrounding structures. And the algorithm is also very perfect. It monitors temperature and impedance, and if there is some problem, it immediately stops. So this is in short about the principle and how it works. And if you look at the histology, this is the typical renal artery, and these red lines are the renal nerves, and this is one ablation, it covers this much zone. So these nerves are ablated. So by raising the temperature, it coagulates the proteins in the nerves, and that is how the nerves are destroyed. And look at the way it hugs the vessel wall. It is very close to vessel wall, and in different dimensions and in different directions, it would give the radio frequency waves. So very elegantly designed. And when you actually, try to imagine how it would be. So if you do radio frequency ablation or RDN, so let us say this patch would get affected, then this patch would get affected, this would get affected, and very important to involve the branch arteries before they enter the parenchyma. And if there is an accessory renal artery, that also should be tackled, because if you leave that accessory renal artery, then you are not doing the job completely. So this is hypothetically how it looks, how the ablation occurs, and you can see the nerves getting affected and ablated. So this is the principle. And this is a renal artery, this is the adventitia, and look at the maximum impact. The maximum impact is in the adventitia and peri-adventitial structures. So this is where the renal, the nerves are and how they are affected without damaging the other tissues. So coming to the trials, so many trials, so many different catheters. So the red trials failed. So simplicity hypertension failed because of the design of the catheter, because of design. So the spiral hypertension off medication, trials, the green trials are the proven trials, and these trials are without sham control group, and this is with sham control group. Means the patients are told that they are going to have a procedure, they are taken to the cath lab, but the procedure is not done, and patient is made to believe that the procedure is being done, just like we give a placebo drug. So all these trials are sham controlled, so that the FDA has made it compulsory that in order to prove the efficacy of an interventional thing in hypertension, it has to be sham controlled. So what are the indications? So hypertension patients, sometimes, of course, uncontrolled blood pressure is one, but borderline control with drugs, patient is not willing to take drugs because of the side effects, or younger patient just don't want to carry it all through the lifetime, drug intolerance, and patient has, let's say he's only on 2 drugs, but he is having hypertension, heart failure, diabetes, stroke, so all comorbid conditions in which the elevated cardiovascular risk is there. All these patients are probable candidates for RDN. And we must understand that when a patient has stage 3 hypertension and has established CVD, diabetes, CKD, the risk is very high. So every millimeter of blood pressure is very important. So let's say patient is diabetic, hypertensive, and blood pressure is very high. He falls in a very high risk group. So you have to control the blood pressure very aggressively. So as a prototype, these are the 4 types of patients who would get benefited. So young or old, everybody gets benefited if you give the option to the patient. So let's say this is a 58-year-old male. He has hypertension, but it is uncontrolled with 4 medications. He has diabetes. He has left ventricular hypertrophy. So mind you, left ventricular hypertrophy on ECG is not a good sign. It's a sign of resistant hypertension. So these are the 4 types of patients, and I will show you how each patient would get benefit. Now this patient is hypertensive diabetic, so 2 risk factors already. Obesity, 3rd risk factor. Left ventricular hypertrophy. Office BP is high. So really not controlled with all these 4 medications, candicertan, atenolol, hydrochlorothiazide, amlodipine. So this is one group of patient, uncontrolled hypertension, cardiovascular risk is high. Second is 60-year-old lady who has hypertension, she has atrial fibrillation, dyslipidemia, type 2 diabetes, significant side effects from hypertensive medicine. So not able to tolerate these drugs. So she is also a candidate for RDN. A young person like this man Antonio, who had a glomerulonephritis at 37, his weight is 108 kg, obese, does not want to take lifelong pharmacy. So he might be a candidate for RDN. And a 74-year-old lady who has suffered a MI, he has hypertension, BP is still high. These are the medications, metoprolol, hydrochlorothiazide, amlodipine, losartan, everything she is on, and since many years. So another candidate who can be benefited by RDN. So different groups of patients, either drug intolerance, unwilling to adhere to the patient, elevated cardiovascular risks, uncontrolled hypertension, various groups of patients who might eventually get helped in future. So, are there supporting guidelines, or is it just a theoretical aspect? So guidelines recommend, of the latest 23 guidelines, so selection of patients to whom RDN is offered should be in shared decision-making process. You have to discuss with the patient. If the GFR is more than 40 and BP is uncontrolled, this patient, by scientific evidence, can be considered for RDN. So, patients unable to tolerate, who express a preference and taking more than 3 drugs are and always keep in mind that it is a patient preference, physician recommendation, and shared decision making. It is not a compulsion. You have to give the option to the patient. So, whenever you talk of any therapy, it is safety, it is efficacy, and durability. So, all these trials of late which had come in 17, 18, the first trial was off-medicine pilot trial, meaning all drugs were stopped and it was proved beyond doubt by RDN you reduce the blood pressure. So that was the first. Then with medications the pilot trial was done, and then the pivotal and full cohort, and finally the global simplicity registry. These all proved that more than 25,000 procedures that it works. And how much does it work? So in absence of medications, after 3 months it brings down the blood pressure by almost 9.2 millimeters. After 6 months in presence of medications, 9.9, 13.1, 20.9 and 16.7. So this after 3 years. So as the days progress, the effectivity becomes more, and that is the beauty of the procedures. So the duration of the effect is almost 3 years still now as per the data, and that is very important. And whether it is a hypertensive, resistant hypertension, whether diabetic, whether it's CKD patient also, -11 is a drop in blood pressure at 3 years in the global simplicity registry. So that is impressive, I thought. Now, one of the off-med pivotal trial proved that, this therapy provides clinically meaningful BP reduction. So 24-hour systolic blood pressure, office systolic blood pressure, 9.2 fall. So as compared to sham control, so RDN is effective. That is what they first proved. And what is important to understand is, when you do renal denervation, look at the baseline blood pressure and look at the 3 months difference. After 3 months the blood pressure falls, and the fall is even preserved at 6 a.m. early morning, where the night time early morning period is a high risk zone associated with increased risk of stroke and cardiovascular events. So even in this period it is, and most important is, the RDN demonstrate always on effect. So unlike a drug, the blood pressure is always on the lower side. So drug, as the effect goes off, blood pressure rises, but this doesn't happen with RDN. After 3 months the blood pressure is low as compared to sham control, in which the blood pressure doesn't fall down. So this is a very important, very impressive slide, I thought. After 3 months, impressive fall in blood pressure. And for nephrologist, it is important that stable kidney function following RDN with, so even after 3 years, the GFR doesn't fall much. There is no damage to the kidneys. That is our concern, because when you do radio frequency, does it damage the renal arteries? Does it cause, GFR to reduce? It doesn't happen like that. So this is proved. And very few complications. Really safe procedure. Sometimes local complications, femoral hematoma can occur. Sometimes renal artery stenosis has been described. Dissection can occur, but then you have to be well prepared for. But the average adverse event is 0.4%, which is quite impressive. So durable effects. So renal nerve viability assessment, if you check at day 7 and day 180, so after RDN there is no viability in the renal nerves, and on the renal nerves there is no medullary sheath. So since there is no medullary sheath, the nerves cannot regenerate properly. And finally, the application of RDN, apart from potential future indications for RDN beyond hypertension currently under, it can be very useful in heart failure. It can be useful in atrial fibrillation. So you do ablation in the heart and you do renal denervation to cut down the sympathetic nerve activity. Ventricular tachycardia, sleep apnea, type 2 diabetes, so many potential uses, but currently under investigation for this wonderful therapy. So, to conclude, RDN fulfills an unmet need in hypertension care in patients. Simplicity blood pressure is safe and effective, and blood pressure drops are sustained for at least 3 years as far as we know as of today, and we wait for the long-term data. Another trial is going to get completed in 26, so we'll have more data on that, and probably it will become a very common procedure in future. Considering that 25,000 procedures have already been done worldwide, and it is now FDA approved. Thank you very much. So this therapy is available in India now, and cost is a concern because it's as always happens with drugs and any research, when initially another technique is ultrasound mediated sympathetic denervation. Apart from this is radio frequency, ultrasound mediated is another way. So there are some ways to instill neurotoxins along the adventitia to damage the sympathetic nerve. That is also the trial is going on. But this maximum work has been done on this therapy. So 29 cases in a country like India is very small, but because of the unlike an angioplasty, when you do angioplasty, you immediately show the block is open. For RDN to work, it takes 6 months. So you can't show immediate benefit to the patient. So it takes time. So when you do RDN, the blood pressure falls slowly over a period of time, 2-3 months. Meaning, it is more the efferent nerve which governs rather than the afferent signals. Because had it been afferent signals, the blood pressure drop should have been dramatic. But if it is efferent, so efferent means it would control the renal absorption. They will give signals, sodium resorption and all. So that is why it is the efferent nerve which probably governs the hypertension in resistant hypertension types. Because it takes time for the therapy to work. It takes 2-3 months for real impact to occur. So that is one of the. Second thing is, there is no way we can predict a patient of resistant hypertension would get benefited by this. There are no markers as of now. And there are no markers also to prove that your therapy has been done justifiably correctly and this patient is going to do well. Because ultimately, the way you approach to a patient, you have to damage those sympathetic nerves. So you have to do it very skillfully, taking all angles, all nerves. So at least 40 to 50% nerves should get affected. Then it will make an impact. And of course, it has to be the resistant hypertension has to be, as I told you, has to be sympathetic driven and not volume dependent. So volume dependent is more common in your patients, but sometimes sympathetic overactivity also takes precedence, particularly when you are using calcium channel blockers, because when you use calcium channel blockers, the sympathetic, there is overactivity, unlike ARBs. So that is the next few years we'll try to find out by some way, is this particular patient likely to benefit by RDN or not? There is no way as such. There is no way to also, give a clue that you have done successfully. So you have to do it and just wait for next 2-3 months for the blood pressure to go down. But overall, it's a new dimension to the whole treatment. So people do get tired of drugs, and then they start showing non-compliance, and that is the biggest problem in practice. We quite often underestimate. So nowadays I have started, when I have a hypertensive patient, I ask them to bring all the drugs with them and ask them to show me what drugs you are actually taking. Sometimes the dose is wrong, they are not taking properly. Even if everything is written, then as doctors we write prescriptions in English, though nowadays we try to write in, but the patients, patient is given prescription, third person is giving the drug. So it is at the mercy of the person who is giving the drug. So compliance, non-adherence is a big issue in hypertension, which is underestimated by clinicians. So such therapy probably would work, and it has worked for 3 years, so that is very important. If it works for only 6 months, it is of no use, any therapy. It works for 3 years at least. So that is the impact it has had. So probably it would take more time, 5 years, 6 years, till we have definitive evidence in terms of more trials, more number of patients. So for the cardiovascular as well as the nephro community to get convinced that no, this is the therapy. And of course the cost, which is, the catheter is costing about 5 to 6 lakhs, which is a big amount in terms of Indian circumstances. It's a lot of cost. But eventually this cost come down, we have seen that. So it would become, and the procedure is not very difficult technically. It is relatively safe also. For a person who is doing angioplasty, doing a RDN should not be very difficult. That is what my perception is. Any questions?
Whether these catheters can be reused, because they are the electrodes, so this should
Yes,
be
Mahendra, can you use can we reuse?
Sir, very valid question. As sir was saying about the cost effectiveness of the catheter, this is like 24 hours, it is time bound, so it actually doesn't work after 24 hours. And within 24 hours, I think you will hardly be able to utilize more than once. So reusability is not recommended with this.
In the cardiology angle, from when you ablate arrhythmia, they are reusing the ablation catheters. So now reusability is always an issue, but I think meaning the cost should come down rather than reusing. It should be reuse. I have a lot of apprehension when we reuse anything. Though we are compelled to use reuse catheters day in and out, but in my practice, at least in cardiology, at least when we do angioplasty, the wires, the balloons, we try to not to reuse, use a new balloon, and this is almost in good centers in Mumbai and Delhi or corporate hospitals. You can't reuse a catheter, so it is more of a compulsion, monetary compulsion, economical angle, but that is not the way to go. I think bringing down the cost to maybe around 2 lakhs or so should be good enough. That would be a great boon to the hypertensive patients.
As we know that the sympathetic nerves, they act through the receptors, alpha receptors and beta receptors.
Yes.
So the use of alpha receptor blocker and the beta blockers in various ways, that can, those patients who show some response to these alpha and beta blockers might be the people who will be showing a positive response to the RDN.
Yeah, actually, they tried a lot of ways to, identify a, patient who is, the right patient for RDN. But despite all their research, they could not come to any definitive, trait or, factor which can. It does not work very well in patients who have isolated systolic hypertension. And it should not be used in fibromuscular dysplasia. It should not be used in renal transplant patients. It should not be used in where technically you find it, procedure might be difficult. So otherwise, generally most of the patients are good candidates, and if despite trying all therapies, every other drug, and if you fail to control the blood pressure, and the blood pressure remains high, 160 office blood pressure, 160, 170 systolic, diastolic also high. So ambulatory blood pressure also you can record, home blood pressure, one of the best ways, the home blood pressure is also high, then probably he will get benefited, and ultimately our cardiologist or our community experience will also tell us a lot. And next 10 years probably we will be able to tell only after 10 years whether it is really working or not. But it is not experimental now. It has been certified by FDA and of course the European Society also. So you have to pick the patients correctly. When the therapy is costly, you have to be very judgmental and very perfect in picking up the patients. So as far as kidneys, CKD patients are concerned, any GFR above 40, 45, and maybe in years to come, below 45 also they are going to include patients now.
As the GFR starts going down, the blood pressure which was to begin with sympathetic nerve related
Yeah.
or angiotensin related, that will gradually convert into fluid overload.
Volume dependent.
Volume
Yeah.
dependent.
Yeah. Absolutely.
So that's why they have put the cutoff mark as 45 ml per minute.
Yeah. So when we do renal transplant, so you put an kidney, do the sympathetic nerves, is there any evidence the sympathetic nerves also grow, or is there any some data on that?
Now, when a transplant is done, that nerve, the kidney is denervated.
Okay, kidney is denervated.
Kidney is denervated. So a person, suppose a person has got a renal stone, he gets a pain, but the patient with a transplant kidney with a stone will not get a pain.
Okay. So those renal transplant patients who have hypertension, so what is the mechanism in those patients? Is it purely volume dependent?
It will be, renin-angiotensin related.
Okay.
Renal artery stenosis, that will be again related to renin-angiotensin. And volume, salt, fluid and salt related. Drug related, the tacrolimus or cyclosporine and steroids that we use in so much quantity. So all these drugs, they themselves can cause hypertension.
Right.
So sir, just a physiological question popped up in my mind. So damaging the nerve will probably lead to the damage to the autoregulatory mechanism of blood pressure in the kidney.
So this in resistant hypertension, this is precisely the autoregulatory mechanism fails. It is the overactivity of the sympathetic nervous system. That is why I have given example of cardiac failure. So why in cardiac failure the drugs like ARNI or beta blockers work? It is because of the sympathetic overactivity, which is till a particular time the sympathetic overactivity is fine, but after a particular time when the sympathetic overactivity is much more than what is needed, then the heart starts failing. That is what the mechanism is in heart failure, and that is why we use all those ARNI drugs and beta blockers, and why do they work in that situation. So similar such analogy for simplicity can be used in resistant hypertension. The sympathetic overactivity is beyond what is required, and that creates the problem. Same mechanism happens in ventricular tachycardia. When a ventricular tachycardia occurs, we give shock to the patient. That is the ultimate. But before that, we give beta blockers. If beta blockers don't work and you have to give repeated shock and the ventricular tachycardia is resistant, then you intubate the patient, ventilate the patient to cut the sympathetic drive. And the last option is sympathetic, the stellate ganglion block. So that is why I shown the last slide. The last slide was actually very thoughtful. Meaning, if you see the slide, there are so many potential applications. One of these is ventricular tachycardia, and now they are trying in atrial fibrillation also. So, in atrial fibrillation, ablation here, pulmonary vein isolation plus ablation in the kidneys also to cut down the sympathetic nerves discharge. Ventricular tachycardia also. Heart failure, chronic heart failure. I don't know much about sleep apnea, but this may be potentially, who knows, something will come out. So from a research point of view, this is, I think, a great thing.
What is that in the center?
The center, they are showing, the two types of, ultrasound and RDN. This is the RDN, and this is the, various ways of, doing renal denervation. Principal two ways. One is ultrasound and second is, the radio frequency. So this may be potential applications, and this is 2023 article, which is the latest article. So I could get few references for heart failure, atrial fibrillation, VT, but I couldn't get references for these two. So the very fact that it has been given in a standard Euro intervention journal means some work must be going on, even in CKD. So thoughtful, very thoughtful, and some logic behind that.
Compliments on such a wonderful presentation. Now there is thought that renal denervation is one site denervation. Now they're talking about multiple site denervations. You have rightly alluded to of the cardiac denervation and other site denervations. So they have gone beyond renal denervation. Good points that you have made.
So this is actually
And there is another thing. They've also started considering renal denervation in patients on hemodialysis.
Okay.
Because hemodialysis patients are susceptible to have resistant hypertension. Very
True.
difficult to control blood pressure. So they have now extended it even for patients on dialysis.
Yeah, maybe. And since there is no evidence, I am only restricting to more than 40 GFR. Because the trials included only those patients whose GFR was more than 40. So I cannot say that it is useful in kidney, CKD patients stage 4 and 5. But if you look at the, the sympathetic nerves, they are more around, the branches. And the mistake they made in the first trial was they focused only on this area. So the denervation was not complete. The catheter was not spiral. It was straight. So it did not do the job properly. Now look at this, ablation areas. It is almost, more than 50% of the nerves are getting affected. And that is why probably it is working. It didn't work in the first trial, but it worked very well in the. And they proved it in patients who are off medications, and they did only RDN in hypertensive patients. They showed that there is a fall in blood pressure with a sham control group also. So no placebo effect. So that was very important. This is also very good, 3D reconstruction of the whole thing.
So just one thought as, will there be any loss of autoregulatory mechanisms that would be there for the renal in case the patient lands up in shock, some related to sepsis? So will there be any effect onto the kidney function, that loss of autoregulatory
Meaning
mechanism?
we have done RDN and in future he lands up in shock. I don't think so, because in shock, the other mechanism, sympathetic drive, is still maintained. No, the signals from the brain, signals from the heart, they are still working. So it is only, we are only, damaging, let's say 50% of the nerves. So 50% are not still not getting damaged. So they, meaning initially the concern was when you do an RDN procedure, whether it would damage the adjacent structures. That is, that concern is no more now. And when you do, you can see some nerves not getting affected. So I don't know in sepsis what happens after 3 years or 4 years, what would happen, but logically it should not interfere in a when you have a response mechanism for a hypotension because of sepsis. I don't think so it would make any difference in such a scenario after few years after doing RDN.
Excellent talk, sir. Just 2 points. If patient has double renal artery, can the same catheter be used?
Because you have to do the procedure in both the renal arteries, not only one side, both sides. If it has a accessory renal artery, so usually you do a CT scan, CT renal angiogram before, so that you are well aware of the renal arteries, where are they. But the accessory renal artery has to be more than 3 millimeter, because the catheter is designed only for 3 to 8 millimeter. So that is the only concern. So small renal arteries may not, but otherwise, and there are so many times there are 2 renal arteries on one side.
In India, which centers they are doing? 25, 26 cases you said they have done till now.
Some, meaning all across India they have done, and they carried first training, and I had gone for training. So you get a certificate. Then there is an exam which you have to pass. So I have given that exam also. So waiting for the right patient now, because as I said, when you talk of costly therapy, from a patient point of view, the expectations are very high. So you have, meaning the patient should be, economically, at least, good enough, or economically he should be able to afford. When you tell a treatment to a patient, he should be able to afford that treatment, and he should be the right patient. So once you get a right patient, we'll try that. It's not a great difficulty. So every cardiologist probably is more judgmental and very reserved in taking this technology. very justified and very truly deserving patient, we are picking up that. That is why the number is less now.
As of now, you said only for 3 years data we have, but
Follow-up data on the
follow-up
Global
data on the
Simplicity Registry, yeah.
registry,
Follow-up data
yeah.
3 and 3, it has shown,
3 years
consistent
reduction,
fall
consistent
in blood
fall.
pressure. That is very
Yeah.
important.
So you expect more fall further? It will continue because, as you
Yeah.
said, there is no myelin sheath and there will be no regeneration of the nerves. So maybe probably that will continue the effect and
Hopefully, I mean, that is what
will
we
be,
think.
yeah,
But
patient will be more ready to
whatever
pay.
scientifically, every time we think, it is not always true. Many therapies fail. There are so many therapies. There are so many concepts which theoretically appear very appealing, but they may not always work in practice.
Yeah, then the cost will be worth if it is long term, maybe longevity
I
if it
think
is
so.
increased. Yeah.
I think so.
Yeah.
It-
Sir
yeah.
wants to make a point.
Since centuries, our saints, munis, rishis, they have impressed upon the fact that the sympathetic activity is the cause of hypertension.
True.
There's some indirect evidence that the person is irritable, person is getting chest pain, or he dies prematurely. The cause is that those who are not stable-minded, they tend to meet with this kind of challenges. Now we say that this is the hypertension, which is the result of this sympathetic stimulation. Now, if we control this by doing naturopathy treatment, meditation, salt restriction, avoiding the drugs that stimulate the sympathetic activity like caffeine,
True.
then probably it will also lower the blood pressure to a certain extent, which is now proved.
Absolutely, because that's why when we
That's
say...
what we are doing it here. We are doing mechanically, but
Mechanically,
what the rishis have said that you can do this way. Even today when we go in the early morning in the garden, we find that people are doing meditation, and
I think that helps a lot.
it helps a lot. So lifestyle modification is a must.
Absolutely.
Thank you so much. Thank you for a nice lecture, sir.
Yes.
Excellent lecture. I hand it over to Dr. Pranav Jha. Vote of thanks.
Thank you so much. And this just shows that nephrologists will be most interested in the hypertension things. Although cardiologist is going to help us with that. So first of all, I would like to thank Jagtap sir for giving such a nice lecture, and that had such a very good discussion. And I would like to invite our chairpersons to please hand over token of appreciation for sir. Yeah, please. Next, I would like to request.
Now I will request Dr. Vandana Bhaskar to felicitate our
First speaker.
Oh.
Please बनिए इसके ऊपर, हाँ, लगा हुआ है.
And I would like to request Ketan sir to please felicitate our chairpersons. Thank you so much, and I would like to thank all the people who have, or the audience who have come here and attended this nice program, and also like to thank Medtronics for helping us out and giving the academic support for the program, and everyone, including Himanshu, who has worked here hard for this. And I would like to request all of you to please join us for the dinner. Thank you. Thank you.